This is the Aware Families Podcast, the show that brings you a science-based, practical look at how to use the principles of functional medicine to keep your family healthy. Welcome back to the Aware Families Podcast. I'm your host, Tom Flass.
And I'm Brittany Coburn.
And we're broadcasting not so live from Functional Medicine Associates of Montana in beautiful Kalispell, Montana.
Yeah, and it is starting. I mean, we're the end of April.
I know,
like we're
spring
so
is springing.
Close. Yes.
After, the winters here are a little long sometimes.
Yeah.
But,
thank goodness
but
we both
wonderful.
love snow.
Yes,
yeah,
exactly.
for
But
sure.
now we're seeing the trees budding up, and pretty soon we're going to see cherry blossoms going, and it's
gorgeous.
Really a great time. And you kind of get that taste of summer, and the days are getting long now, so it's staying light late, and we get what's called manic Montana. So when you're this far north of the equator, you have long winter nights, but then when you hit kind of close to summer, the days last a long time, and people just kind of get manic.
Right. Well, yeah, because it can be 11.
Yeah.
Right before everything is dark.
Yeah.
I know. Hard for kids. The other thing is, and we'll cover this on a future podcast, but allergy season, man.
Oh, yeah.
You know, it's
It's different,
starting.
but it's for real. You know,
It
there's
is.
like an East Coast allergy thing that's, where it's
I don't really know that.
super
Yeah.
humid and people get shellacked. But I think it just sort of depends on what you're sensitive to. And, now the pollen, all the pine trees are dropping the pollen, so you get that green scrum all over your car and everything like that. So if people are sensitive to that, this is a difficult season for them.
Oh,
and then
for sure.
we get things like cottonwoods that'll be blooming,
Grass.
And, all the grasses. So all the good stuff.
Yeah.
We don't have dust mites, and things like that. So we're good on that front.
Yeah.
But we're not going to talk about allergies today.
No, not yet.
We are going to talk about, we're going back to poop again, I guess,
Yes.
so it's like hormones, poop, what else is there to talk about? But we're going to talk about irritable bowel syndrome, or IBS. And so I'd lovingly titled this IBS or BS, so are we just symptom managing, or are we actually looking for underlying root cause, which is what functional medicine is all about. So.
For sure. Well, okay, before we jump into it though, so, you say IBS. Can you explain IBS so that we have a definition of what, and maybe like the full on name?
Yeah. So, and first thing is to differentiate. There's IBS and there's IBD, and people get those. Even practitioners get those mixed up all the time. And so, IBS is irritable bowel syndrome, and IBD is inflammatory bowel disease, meaning Crohn's and colitis. So very different. And specifically, IBS is not those other, more intense inflammatory conditions, although people with Crohn's and colitis are also more prone to have an overlay of irritable bowel on top of it, which makes it confusing to try to figure out what you're managing, and you need to kind of check the right things.
Yeah.
But so irritable bowel syndrome is classically been labeled as what's called a functional abdominal disorder, meaning like it doesn't really have an organic cause, which I think is an erroneous line of thinking, because as we'll talk about, we're definitely finding out more things about IBS that show that there are some very detectable physiologic things going on, and that it's not just like, oh, it's all in your head, or things like that.
Right, which sounds awfully familiar, right, to the hormone conversation of, oh, it's just what happens. It's just in your head. It's just this is the time of life you're going through.
Yep. Just deal with it.
Just deal.
So IBS is been defined and redefined multiple times. So the more recent diagnostic criteria are based off what's called the Rome 4 criteria, which again are these gastroenterologists that met up in Rome and drank wine and talked about tummy pain and poop for a week or however long they were talking for. So it's gotten revised periodically. This last one, the Rome 4 criteria, was in 2016. And so characterized by recurrent abdominal pain, an average of at least 1 day a week over the last 3 months, associated with 2 or more of the following. So 2 or more of improvement after you poop, onset associated with a change in the frequency of stool, either like less than average or more than average, so either constipation or diarrhea. And onset is associated with a change in the appearance of the stool as gauged by the ever familiar Bristol stool chart, which I use all the time. And we keep a copy in the offices.
I actually have a copy right here.
Yeah.
Yep, sitting right under.
Should we show the crowd?
Yeah.
And if you've ever been to a gastroenterologist, likely you've seen this chart, but it really is, a picture is worth 1,000 words. And so, and especially for kids who are like maybe embarrassed or whatever, they can point to their poop and say, choose your poo.
Right. Yeah. Like, what did it look like this morning? So it makes it a little bit more concrete, a little more real.
Yeah,
when we can point to it.
And other providers will know, say, oh, they are having Bristol 1 and Bristol 6, and then they'll know exactly what you're talking about based on that. So,
and you can Google that just so people know.
Yeah,
you can literally find this chart, even with different colors.
Google images.
On Google.
Yeah. And but if you want it laminated, you could probably order a special one.
Right, true.
So there's subtypes of irritable bowel, and so the 4 subtypes are IBS-C or IBS. It's predominantly with constipation, IBS with diarrhea.
And so for constipation, real fast, how are we going to define constipation
for
folks?
Less than 3 poops a week.
Okay.
Presence of really large, hard stools, discomfort with passing the stool. Those are probably the biggest things, so like hard stool, less than 3 a week.
So more firm, it kind of hurts, and it's not every day.
Yeah, exactly.
Okay.
And then diarrhea is, obviously diarrhea.
Right.
And that it's variable, but, with, again, if you're looking at Bristol 6 or 7 on the poop chart, really no form to the stool, that would be sort of characterizing that. And then there's a mixed type where you kind of flip-flop back and forth. And I see this all the time, and I'm sure you do as well.
All the time. Yep.
Or I'll say, like, hold up the Bristol stool chart and be like, and they'll be like, yes, like all of them. So that's definitely a mixed type where they're kind of running the gamut.
Yeah.
And then there's this uncharacterized where it's more pain and maybe there's some stool stuff, but not quite as well defined. And so, but it's interesting because obviously it's not always static. Like the symptoms can change over time.
Right.
They can change within that person. They can change within the context of certain things. So, it does make that part of the diagnosis a little bit more difficult.
Well, and we talked about this with our last podcast with perimenopause. So hormonal influence, right? So in one 28-day cycle, your stools change.
Oh, and we're gonna talk about that later, which doesn't get talked about a whole lot. But
not enough. No. And so, but that can add to the difficulty in diagnosis, right? When it's like, well, I had, 4 days of really loose stools right before my cycle, right? But maybe that part doesn't come out or doesn't get asked.
Yeah. Yep. And then how much of that is normal versus is that some sort of, excessive hormonal shift or something along those lines? So
because a lot of it can be normal.
Which does segue, and this kind of jumps ahead a little bit to the epidemiology of it, but women are 50% more likely to be diagnosed with IBS than men.
Yes.
And so that's probably part of it.
I was just going to say, in addition to the hormonal component, what else? What are other reasons you think?
Well, let's get into that later.
Okay. So all right,
so I'll finish off the diagnostic part of it. So there's some other criteria, but really that Rome 4 criteria that we just talked about is kind of the main thing. And it's kind of evolved over time, that diagnosis. And it's tough because it's still there. Is it a diagnosis of exclusion or not? And this is where I think functional medicine and the typical conventional approach may differ.
And diagnosis of exclusion, to us makes perfect sense, but to somebody else it might mean that we have basically ruled out all these other causes, and then this is what is left. So that's when we use that term, diagnosis of exclusion.
And the concern in traditional Western medicine is more, excessive testing. We're trying to avoid the excessive cost and the excessive time and effort for doing excessive testing. But the flip side of that is not testing at all or not testing enough and missing certain things that we'll talk about in a minute. So that's where I think where there's definitely a sort of a different mindset
and different approach.
Yeah.
Yep.
And so what they always want to make sure is like that there's not a quote unquote organic etiology. And what that means is it's not Crohn's, it's not ulcerative colitis, it's not celiac or something like that. But that whole thing with the organic etiology is also a little weird too, because the things that we're starting to know about IBS and some of the associations with when they do biopsies, say they do an endoscopy, colonoscopy for somebody that ends up getting dubbed as having irritable bowel syndrome, that there are changes. There's some inflammatory changes. There's some other interesting things. So it's like, well, then it's not all in your head. There's some physiologic things going on. You just don't have a great definition of what that is or what exactly is causing that. Which again, we'll talk about that pathophysiology in a second. But it's kind of interesting that there are So IBS is associated with a marked reduction in quality of life, health-related quality of life. So there's higher rates of what's called somatization, which again, that sort of rubs a lot of people the wrong way. I think it's sort of like, oh, they're like a malingerer, or they're just a bellyacher, right? I mean, that's like that used to be the term. Well, this person's just a bellyacher.
When really they might actually have belly aches most days of the week.
Yeah,
right.
Yeah.
Which, think about it, when you have a tummy ache, regardless of the cause, it still impairs your quality of life.
Exactly.
So even if it's IBS, even if it's anxiety, right? Even if it's hormones, your quality of life is impacted.
Yeah.
Period.
And there's a known association with psychological comorbidity.
Right.
But is that chicken or egg?
Exactly.
And also the brain gut link.
I was going to say, we could talk for an hour on that. I mean, a day on that.
and yeah, an hour or
a day.
Many hours.
Yeah.
But that this, IBS kind of falling under a category of this it used to be called, again, functional disorders. And now it's getting renamed as disorders of gut-brain interaction, or DGBI. And this is literally the new classification, which I think is a huge advancement because of getting eye rolling for years and kind of a disregard for all these things.
Huge.
But these are a disorder of gut-brain interaction. We know that through the vagus nerve and other and actually through the blood, that the gut and the brain and the microbiome and whatever's going on in your gut is also going on in your brain, and that's a two-way street.
Right.
So that has a huge impact on I guess the sort of the pathophysiology of irritable bowel, and is part of it, and is not a cause to think like, oh, this is all in your head, or you just stressed out, or other things like that. But that
related.
may be a component of it. But is it your gut stressing your brain out, or your brain stressing your gut out, or is it both?
Right. And instead of thinking them as two different cities not connected by a highway, right? Instead, maybe they have that massive highway that we're finally recognizing.
And address both.
Addressing both
instead of like, this kind of siloed thing.
Right.
But there is, with IBS, there's increased incidence of depression, suicidal ideation, loss of productivity, loss of work.
And again, for all the reasons you just said, could they be, one leading to the other, or is it both leading to both?
Yeah. And so, how big of a problem is this? I mean, it's literally in the tens of millions of people.
Yeah.
So they've done some new worldwide studies where they kind of combined all the research done on IBS and pooled all that. So they think worldwide prevalence is about 4%. Estimates in the U.S. are closer to 5%. And so if you do the math, in the U.S., depending on what exactly the population is, if it's like 320, 330 million. So 5% times 320 million is 16 million Americans with IBS. And it's pretty well recognized that it's probably an underdiagnosis, because a lot of people don't go seek care for it because they're like,
I have a stomach ache.
Yeah.
I'm not going to go in.
Or especially like the male population that's just like, they're normal. It's like their guts are in a wreck and they just don't want to go see the doctor about it. Or there's certain also
because they might be living with it, and tolerating
and thinking
it.
that that's they're normal and not knowing that their life could be better.
Because that's another thing. Don't you ask people all the time, how are your stools? And I try to never say, are they normal?
Yeah.
Because your normal and my normal might look very different, right? Your normal might be all 6 of these in a week.
And which is, again, where doing stuff like the Bristol stool chart and just, basing off of like the Rome criteria type of stuff, like, are they meeting the definition of having constipation or diarrhea or kind of the alternating? But I don't think that's a reason to not think about the deeper underlying causes and the root causes in the upstream, what they call the ATMs, the antecedents, triggers, and mediators, which is, we go through a lot in functional medicine training.
Right.
So 12% of patients seek medical help in primary care. So basically 12% of primary care visits over a certain length of time were attributed to irritable bowel. So, which is a crazy.
And again, but I also think that's low.
Yeah.
I really do, because how many times, did I have somebody coming in for a primary care visit of anything, and that would come up.
Yeah.
So that wasn't the reason for the visit, and might not have even made the diagnosis list.
I know,
honestly.
because you sent some patients over to me. They're like, going over the things like, and then you're like, oh, this person's guts are a wreck, and we need to look into this because that, as we know, everything impacts everything else.
Yes,
so and all disease starts in the gut. Going back 2,500 years.
Exactly.
But I think the other thing that we both noticed is a lot of these patients with, quote unquote, irritable bowel. And I always I kind of hate that term too, because I think it's what's called a wastebasket diagnosis, where it's just like, oh, you have these, it's like you have poops a lot syndrome, or you have not poops enough syndrome. It's like, great, thanks. Tell me something I don't know. But a lot of these patients feel very disregarded and kind of,
Yeah.
like they're maybe
Totally.
not being listened to, or that somebody maybe isn't doing a little bit, sort of a deep enough dive to try to figure out the underlying causes. And this is not a slam against, other healthcare providers and things like that, because a lot of people are not advocating for themselves well enough, or they
Right.
don't talk about it. They're talking about these other things.
It's still so taboo, right? To bring up poop. Like, it just is. It's just not a thing anybody wants to mention. When you call a clinic to make an appointment, you're not going to say, I have a poops a lot syndrome, right? Or I have a not poops enough syndrome. Like,
versus in pediatrics is a little different because especially
yeah.
for parents who have kids with pooping
Right.
issues on either side of the spectrum,
Right.
it becomes sometimes
Right.
a hyper focus.
Yeah.
And maybe they're talking about it too much.
Yeah.
But that's a whole other story.
well, so yeah, maybe it's more of like our demographic of, age 10 to 60.
Yeah.
And then at some point we do start thinking
there's
about
nothing
it
a
again.
teenage female loves more than coming into my office and talking about their
talking
poop. It's usually the highlight of their day. So.
Oh, for sure. I know. We have to preface those conversations with, hey, okay, these are weird. This is going to be a little bit weird.
It's a poop safe zone.
Yes,
we gotta
yes,
talk about here.
I know. Yeah.
And if we improve your quality of life, if you feel better, it's well worth it. Yeah.
For sure. For sure. And sometimes, you just don't, you might be having those symptoms. And when we finally can talk about it and actually get, more of their perspective on it and their understanding or their description, it helps us make the diagnosis easier, or at least leads us down the path of what we should be investigating.
Yeah.
Versus, a checklist of nope, no constipation, no diarrhea.
Yeah.
But if they're like, well, actually, I have a rumbling tummy and I kind of double over, but then I go to the bathroom and it's fine.
Yeah.
That means a lot to us.
And it's interesting, talking about where they are on the diagnostic spectrum.
Yeah.
And one of the recent studies that was published where they're kind of redefining and looking to see what's called the sensitivity and specificity of the Rome 4 criteria.
Oh, yeah.
Which means how sensitive is it? Meaning what percentage of the cases that are out there are you actually picking up? Is it sensitive enough? Meaning you're picking up most of the patients who do have this specific disorder, disease, and specificity is how many times are you getting either a false positive, and hopefully you have a low false positive rate, so that when you're detecting it, it actually is what you say it is.
Right.
But on that note, they actually the researchers commented the patients who were the scores were the highest, meaning the test, the Rome 4 was the highest sensitivity and specificity, had a complete blood count to make sure they weren't anemic. They had a CRP, which is this inflammatory marker. They had a celiac screening done, which we'll talk about in a minute, and 1 out of 100 Americans has, and a hugely underdiagnosed population cause of quote-unquote IBS, maybe undiagnosed celiac.
Right.
And then if they had diarrhea, they also ran what's called a fecal calprotectin, which is an inflammatory marker, very good, very sensitive and specific for picking up occult hidden Crohn's or colitis, some type of significant inflammation that then if it's high enough, then that really warrants you need to go get it scopes, endoscopy, colonoscopy to see where the inflammation is coming from. And if they had those and those were normal, then, which I think is a great first line evaluation, then it may be more likely to be irritable bowel, but there's a whole bunch of other things that we do as functional medicine providers that aren't necessarily done in the standard setting that are evidence-based and have huge bearing on the symptoms.
Yeah, and improve quality of life, right? And so, it's step one is, rule out those big modifiable ones that we really need.
Don't miss this.
Don't miss this. And so what would be some of those symptoms be when we're, if somebody's going into primary care and we're heading for a scope, right? Or a colonoscopy or an EGD, the upper. What are some of those main symptoms that you would be anticipating?
Well, obviously, recurrent blood in the stool.
Okay. And what about this? Is it a certain color? Is it a certain amount? Is it, just a little tiny bit when I wipe?
Well, I would say the 3 colors that you pay attention to with poop are black, white, and red.
There you go. Okay. That's great.
So, and white is called acolic stools. That usually means that the bile isn't making it through. Right. So in a baby, that can be some signs of some serious liver disease, liver gallbladder disease, and warrants paying attention to. Older on, if somebody had a gallstone that got stuck or something like that, kind of plugging up the bile. Obviously, you're going to probably have more symptoms than just that, but that can result in those kind of white, really pasty, pale colored stools, the color of our walls in here.
Not this color, but the other color.
Yeah, that would be a little bit light green. That would mean you're probably on a clean out or something like that. And then black can represent upper gastrointestinal bleeding. So if you had like a bleeding ulcer in your stomach or duodenum, as that blood travels through the GI tract and gets oxidized and the enzymes and stuff interact with it, then it turns dark black and like tarry, sticky black, that's a GI bleed.
So sometimes we'll say dark tarry stools, right? They're dark. They're maybe, maybe not like specific black, like this black, but like it looks super dark. So,
and then red, like obvious blood red,
Right.
Not like food coloring red. And there's like easy little what's called hemoccult tests and things like that. You can detect things like that. But that's probably the biggest things to look for. And then the other hallmark things: are they losing weight?
Yep.
Did they screen positive for kind of unexplained anemia or iron deficiency? Some of those things. I think those are probably the big ones as far as like red flag type of things. Are there other systemic things going on that means like there's probably some systemic inflammatory condition?
Right.
So those are the things I usually think about.
Perfect. Well, it's good to know, right? So that kind of people can kind of be thinking about like, oh, okay, this would be a reason to maybe take this a step further.
But it doesn't mean if none of those red flags are there that there isn't something else going on, which we'll talk about in a second, like going through our list of things. So I think that's where the rubber meets the road for irritable bowel. And as far as the pathophysiology, like underlying things, it's funny because even in the Western literature, I'm quoting a recent research article. It says the pathophysiology of IBS is broad and includes abnormalities, including motility, like the way stuff moves through your guts, visceral sensation, which is like that kind of it's called afferent, like the pain receptors and some of the sensory receptors in the gut,
right.
Brain-gut interaction and psychosocial distress. And then, these factors can be identified in the majority of IBS patients. Recent studies have also shown that altered gut immune activation, changes in the intestinal and colonic microbiome are associated with IBS. So they're starting to be like veering off, like, okay, there's some other things going on.
Right.
And it's not just like all in your head.
Right.
And then when they've done, like I said, when they've done the biopsies on some of these patients with irritable bowel, it's like, not normal. It's normal, meaning like there's no Crohn's or colitis, but they've noticed things like increased inflammatory cells, something called mast cells, which we will talk about in a minute because you have experience with some of the mast cell type disorders.
Right.
There's the enteric nerves, like the nerves of the gut are different, or there's mast cells clustered around these nerves. I mean, that can be a kind of a hallmark thing with irritable bowel. And then there's more T cells, these immune cells in the mucosal layer of the patients with IBS, especially the diarrheal ones. And there can be different things with some of these things, neurotransmitters, they can detect that there's differences. So there's stuff going on. It's just, again, it's more subtle.
Right. But all of that type of thing you just mentioned, we determine that with a biopsy. So that's when you're having a colonoscopy
which is not to say that every patient but on the studies that they have done, it just tells us like these are things to think about, and are there non-invasive things we could do to sort of detect that, or when we look at it from the functional medicine mindset.
Right. Yeah.
So.
Yep. So a little bit of a different perspective. So understanding, okay, we have these symptoms, we have this going on, we have some clues in our, in our minds. What would be some of the next steps to do?
Yeah, and the first one you already talked about, right? Like rule out the big bad stuff. So that if that hasn't been done at the primary care setting, then we always do that first. So again, the big things: making sure it's not inflammatory bowel disease, which, especially in the case of Crohn's, can be sneaky. But that fecal calprotectin is a great test,
right?
And that's can be,
and that can be ordered anywhere. So your primary care can do it. Obviously, we do it here a lot.
I tell my patients the poop never lies. The blood work can lie, but the poop never lies.
That's a good one. Okay.
But so there's that, and a celiac screening. Again, right now in Italy, universal screening has been enacted. Every person, and I know every kid, but I don't know if it's every adult as well. So when you think about it, 1 out of 100 people in the U.S. has celiac, according to, and actually maybe even more than that, based on some of the research coming out of Children's Hospital Colorado and in conjunction with the Barbara Davis Center, because celiac and type 1 diabetes are on the same gene. So they're kind of doing a lot of these genetic type of research things, and they've done a lot of, and they're screening for antibodies for, like, before people get type 1 diabetes, there's certain antibodies you can screen for as well. So they're doing a lot of really cool research on this. And based on these huge pools of like banked blood that they've had from just other blood draws that people have had, and in the tens of thousands, and they went through and tested the celiac antibodies, and it used to be thought it was like maybe 1 out of 200, 1 out of 500, something like that, and then they're like somewhere between like 1 out of 50 and 1 out of 100 patients, and former colleague of mine, or former attending when I was training down there, has come out with this. And at first people were like, no way. But then that got backed up and repeated. So we know that it's at least 1 in 100.
That is significant.
Yeah, that's significant. We screen for a lot of things that are way less common than celiac.
Oh, yeah.
And they call celiac the great imitator. Can present with just abdominal pain, diarrhea, or constipation, or both, or neither, unexplained iron deficiency, all these different things. And so,
Funny periods.
Yeah.
Seriously.
Any unexplained GI symptoms, automatically,
test,
no question, send a celiac screening.
Right.
So for older kids
easy.
and adults, easy. It's what's called a TTG, or tissue transglutaminase test. And the IgA version of that, which means that that's the antibody that you're checking for. So a TTG, IgA, and a total IgA, or total immunoglobulin A, because up to 5% of the population, they don't make much of that one type of protein called IgA, which then kind of negates the test, and then you need to kind of do a sort of a follow-up test on that. For younger kids, I also often send what's called the DGP, or deamidated gliadin peptides, which may be a little more accurate for kids under 3. And certainly you can use those for adults as well. But again, like the sensitivity and specificity of that TTG IgA test is pretty good. It's in the low to mid 90s. So, maybe like a 5% chance you could miss it, but it's a pretty darn good. As far as screening tests go, it's pretty darn good.
Right. Yeah. Worthwhile to do for sure.
Yep. So other things like that, but then again, the Crohn's thing, that's more, and unfortunately that's increasing in both the number of people and decreasing age of diagnosis. So we're diagnosed. I mean, I've diagnosed kids 18 months old with Crohn's.
Wow.
So it's unfortunate.
Yeah, because we used to say that was we would diagnose that older, like in your 20s.
Yeah, but it's unfortunately it's like
wow.
Age range is going down.
For sure.
Other things to think about, especially for anybody who's had their gallbladder out, is something called bile acid diarrhea.
Right.
That's not uncommon at all. And when you don't reabsorb your bile, because normally your bile gets secreted by your liver, squirted out from your gallbladder when you're eating a fatty meal. Your body kind of senses that, mixes, helps digest the fat, and then you reabsorb it at the very end of your small intestine, called your ileum, and then you recycle it so you don't have to be making it all the time. But if you don't absorb that bile, it's really irritating to the colon, and so you can get these kind of burning, urgent diarrhea, especially after you eat. And people who have their gallbladder out, they can't regulate that bile flow, and so it's not uncommon that they have this bile acid diarrhea. And then you do the right things for that, boom, its symptoms get way better.
Right.
So it can happen even if you haven't had your gallbladder out, but for certainly the people that are post what's called the cholecystectomy, post surgery to get the gallbladder out, that is a known commodity and not uncommon at all.
Right.
And then there's other tricky things like microscopic colitis, which is just as it sounds, like it's not like a full raging ulcerative colitis, but you do the biopsies and you see that there's something going on there that's kind of an autoimmune thing. It's still a little bit mysterious, and can sometimes respond to dietary.
And they can be hard to find.
Yeah.
Those ones can be hard.
Yep. So and never discount medication side effects.
Right. I was going to say, because you never know. Sometimes you're doing one thing and you think you're doing just the right thing, or you're helping, or even supplements, right?
Yeah.
And the side effects are gut related.
So always look at that. And it's again, it's a no one size fits all, the N of one approach. Like some people take that one medication or whatever and they're fine. Other people, it just shreds their gut, causes horrible constipation. So just other things to kind of keep in mind. But then, all right, so root cause. Let's talk about root cause.
Right. Well, which is what we do all the time, right? So that's where once you've said, we have that initial evaluation and we're like, okay, we don't see these big things, but we're still having symptoms. Instead of us just saying, okay, here, take this, let's take care of the symptoms. We want to backtrack and figure out, well, why are these symptoms happening?
Exactly.
Like what could be what could we be looking at? So when we sit down and talk to people, we have a very extensive protocol, right? So what are some of your top go-to questions when you're investigating root cause here?
Well, we do, and the thing is, like, people come in and we do a from birth type of history, right? So, and it's interesting because the length of time that takes depends on if they are 10 or if they're 70, so there's can be some other history, but still it can inform like the fact if they were C-section versus vaginal birth. Like I start to think like what could have messed up their gut microbiome, which I think is a huge, even in the Western literature now, they're admitting like that has a huge role in driving, obviously everything from Crohn's and colitis, but irritable bowel,
Right.
other GI
Allergies.
disorders.
Yeah.
Yep. So are things like, if they're C-section birth and formula fed, they probably didn't get the inoculum of good bacteria
Right.
when they were an infant, which kind of kicks off a healthy microbiome. So again, there's not a judgment. There's nothing, nobody did anything wrong, but we're starting to discover the power of that, the inoculum going through the birth canal and getting those probiotic bacteria. And then the breast milk has its own microbiome that it takes from the mother. It's genius. And then gives the bacteria to the baby through the breast milk. So if babies lose out on that, they can start off with they're kind of a GI setup for different down the
Even
line
if
GI
to
stuff.
no fault of anyone, because sometimes sometimes those are just not options, and so we know that, and it's just something that we note so that we can say, oh, okay, we're going to look at this.
And then those kids that may have been the otitis, the recurring ear infection or strep kids, and they get pummeled with antibiotics, further wipes out their gut bacteria, and they're set up for, again, that we know they're increased risk for Crohn's and colitis, but also irritable bowel type of things.
Right.
Or as an adult, if you went through, say you had recurrent UTIs and you're taking a bunch of antibiotics. So I always try to think about that, like what could have messed up their microbiome from that kind of standpoint, medications, antibiotics, diet.
Diet is huge, right? So are we on the standard American diet? Are we getting a lot of sugar? Is our insulin and glucose always high? Are we getting, like you mentioned before, a lot of those fats? Are we getting protein? What kind of protein? Is it all super ultra processed protein or what food-like substance, right? Another way to talk about ultra processed.
Yeah.
Are you getting vegetables and fruit? I know we've talked about this with that youth risk behavior survey that they do nationally, and they'll ask, students in 7th, 9th, and 11th grades, how many salads do you eat on average a week? Right.
Yeah.
And those can lead to this too.
And we're kind of doing that as our fiber scan. Like how much fiber is this person actually getting?
Yeah.
Not just because it's a fiber helping you poop,
right.
which it does.
But is it feeding your bacteria? Are we feeding those good critters,
or
right?
Or those suckers starved, which I'd say most people, they're starved.
Right.
People should be getting, 25, like adults, 25 to 35 to 40 grams of fiber a day.
Yeah.
And the average is like 10 to 15.
Right.
So,
and I think even sometimes that's generous.
Yeah.
So
yeah.
we usually will do a full discussion, which you can reference back to our nutritional podcast that we did, but where we talk about soluble and insoluble fiber at length.
Yeah. Yeah. And then, but also travel history. Could they have been exposed to some interesting critters?
Right. And, parasites, all kinds of stuff. There's a lot there.
Yeah. Which, again, not everything is parasites.
No,
there's some kind of mindset.
Other stuff.
But if somebody's got a history where they spent time in the jungle in Central and South America, if they were in, in Southeast Asia doing some stuff, or, other things like that. Even in the U.S., though, Cryptosporidium and Giardia, which are really the main parasites you'd see in the U.S.
We see them up here.
Yeah, we see them up here. People are rafting, spending time in the water.
Camping,
you take a mouthful of water at the wrong time, and then,
Yeah, so we actually see that a fair amount, actually. Yep. So in primary care, those would be some of the, someone would come in with an acute 3 weeks of diarrhea, right? Yep. Like I didn't have it, I went camping, and, a couple days later, I have 3 weeks.
That ain't IBS. There's a critter in your belly.
The other interesting thing is I've seen it with kiddos eating snow.
Ooh.
Yep.
Never eat the yellow snow.
Right. But maybe not even the white.
Yeah. Maybe not, yes. I think it's probably good advice.
Just saying.
Or just take it with some Flagyl or something.
Right.
And then other things with the microbiome. So there's kind of those big picture things that we kind of think about. But then if we break it down into like big
like
categories,
buckets?
Big buckets that we think about. So there's, I think, a microbiome bucket, which includes things like the occult infections.
Yep. Which occult means hidden.
Hidden infection. Yep. Dysbiosis.
Yes.
Which is just sort of a general term meaning like it's imbalanced, like the microbiome is imbalanced.
Mm-hmm. There's maybe more bad bacteria than good bacteria, or certainly the balance isn't there.
And then what we see, and actually there's been studies that show that up to 20 to 30% of adults in this one IBS study had some element like definable SIBO or small intestinal bacterial overgrowth.
Yeah.
So I think this has been under-recognized.
Yeah. Well, and then what about small intestinal fungal overgrowth?
Yeah, which can piggyback. So there's SIBO, small intestinal bacterial overgrowth, SIFO, or small intestinal fungal overgrowth like Candida and some other fungi. And they can coexist, and they like to kind of piggyback.
Right. And you can see a lot of bloating with this. You can see a lot of like that food baby, right, that you end up stuck with in your tummy.
But also sugar cravings on the flip side of that. And sugar makes the symptoms worse, but then you're also craving the sugar. Yep. So, and then you have the bowel and the other gut symptoms and the discomfort.
looks a lot like IBS,
Yeah,
right?
yeah.
I mean, so that's the thing. All of these things.
I mean, by definition,
Yep.
it is IBS,
Exactly.
but if you're not looking
why?
upstream for the root cause
Exactly.
of something like that. So this is something we test for all the time
Yep.
At Functional Medicine Associates, and so
Mm-hmm.
again, we talked about travel history, antibiotic history, dietary history. So what about food sensitivities and intolerances? Maybe we should subdefine some of those.
Right. Yeah. And again, to be clear, we'll definitely have another podcast
Just on that.
specifically about this, just because we could talk for a long time about these.
Yeah.
But yeah, so there's certain foods that can increase your symptoms, right? So you can have issues with lactose, fructose. We talk about like the FODMAP, and we,
Those are intolerances, right?
Yes.
So what's the difference between an intolerance and a sensitivity?
So if you, and then an allergy, right?
And an
so
allergy,
you can have
yep.
a food allergy or an IgE reaction where you are going to have some type of an anaphylaxis, right? Whether that be like GI, nausea, vomiting, hives, breathing difficulties, heart rate spikes, right?
Yeah.
But some kind of an IgE reaction there.
Which are pretty immediate.
Yeah, and they're within like 30 minutes,
Yeah.
we usually say. And so, those ones you usually don't miss.
Yeah.
It's like, you get stung by a bee and you have issues.
Yeah.
Right? Same kind of thing, but with food. And then food sensitivity or an IgG reaction, those can take...
Or T-cell mediated.
Oh, yeah.
Sneaky. Delayed.
Yep.
Delayed
They can take
sensitivities.
72 hours.
Yep.
And so I don't know about you, but I have a hard time remembering what I ate this morning, let alone 3 days ago. And then equating that to the cause of my symptoms.
Yeah.
So
because
those
it's not immediate.
Yeah.
But can certainly cause
they can cause a lot of
IBS type of
issues.
symptoms.
Right. And then you can have intolerance. We talk about histamine and histamine intolerance. And, this jumps into the mast cell and all of those things you were mentioning earlier. And again, I think we should have a whole podcast on mastocytosis and mast cell activation syndromes. But yeah, you can have certain foods that are either high histamine containing foods or high histamine releasing foods. And they can trigger those intolerant symptoms.
Yep.
So headaches, heart rate spikes.
And that's a
nausea,
totally evolving
vomiting.
field. It seems like we're just still trying to figure that
Very
whole thing
much.
out.
That used to be kind of considered in those rare diseases, and now it's like, no, actually these are actually quite common. We don't test for them because we don't really know. We're still researching them. We're still learning a lot about them.
Yep.
But there is a lot out there that we do know already and that we can be investigating.
Yeah.
And
Versus lactose intolerance, it's sort of
Yeah.
like almost like a not a running joke, but they've done some studies where like 70% of the world adult population is to some degree lactose intolerant.
Right.
So it's exceedingly common. It's on a spectrum of like how, and that's
Right.
basically meaning, so lactose intolerance and milk sensitivity are two different things. So some people conflate the two, but lactose intolerance just means you don't have enough of that lactase, the milk sugar lactose. You don't have enough of the enzyme to break that down, and if you don't break it down, then it gets fermented and sucks water into your GI tract, so you get the bloating and then sometimes nausea and diarrhea and all those things. Like if you have lactose intolerance and eat a pint of Ben and Jerry's, and it's probably going to be a good night. But and fructose, people don't realize this too, but fructose, even though it's not a breakdown thing, but some people just have they're limited how much of that fructose sugar they can absorb at any given time. So it's like a glass ceiling, like a little bit of fruit that has some fiber and kind of a time release fructose, they're fine with. They
Right.
chug a big thing of soda with high fructose corn syrup, and it's lights out for their
Right.
belly.
Yeah.
So, that's a lot more common than people think too.
and I think we often want to relate it to other things, right? And so, but yes, I agree. I think
Can't be the sugar.
Yeah.
It just can't be.
Well, because sugar's everywhere too.
Yeah.
And so it's really hard, like until you start reading labels and looking, and then also, we should post this on our website. You have that great page out of one of your books that talks about all the different names for sugar, because it's sneaky.
Yeah. Yeah.
It's so sneaky.
Like in the hundreds of names for
Yes.
sugar, added sugar.
And like what all they mean, but yet what they're doing to our system. So all of those can contribute to different symptoms.
Exactly.
So no wonder people are confused.
Yeah.
I mean, we all get confused. It's like, wait a second, is that? Yeah.
And then milk intolerance, which is where your body is having a subtle immune reaction. And this can start but it's not exclusively for infants. Like cow's milk
Right.
protein intolerance, very well diagnosed thing. Like especially even the breastfed baby, mom's eating dairy. Some of the milk, the cow's milk protein comes out through her breast milk, and the baby has a little bit of blood in the stools. Usually fairly harmless and goes away. But there's I think it doesn't always go away. I think it's a lot more times it goes underground or morphs and turns into something different. But milk is the most common allergen in the human diet. There's no question about that. And it can take many different forms. And so some people are sensitized to the milk protein. And it's interesting now there's coming out, everybody's probably seen the A2 milk, And so what that is a breed of cows that makes a protein called casein that's more like the type of milk you would find in a goat and a sheep, which some people tolerate better. And there's been some studies on this, people who thought they were lactose intolerant and then switched over to the A2 products. So whether they switched over to goat milk or, goat products, sheep products, or this A2 cows that they found that, are making that protein that's a little bit different. And all of a sudden they're like, oh, my gut
is better.
My irritable bowel is better. So things like that are always stuff to consider as well.
And they even have some of that at like Costco.
Yeah, it's becoming, and some dairies are going entirely A2. So it's interesting.
Yeah, for sure.
Inflammation, immune activation, again, that's sort of part of all this thing, and many roads to that inflammation and immune activation, including neurologic, stress, infections, food sensitivities. So
we know, one of the things you get stressed out and your tummy is upset, right? Some of us carry our stress is like directly related.
Yep, the highway runs strong in that one.
Yes, for sure. But that's the thing, right? And so then we have to sometimes reevaluate stress as that like root cause.
Hence why they call it the brain gut axis.
Yep.
And and which ties into that whole vagal dysfunction or low vagal tone.
Right. Yeah. And how we talk a lot about, and we've done this in a previous podcast as well, but belly breathing, right? And how that can help because that vagus nerves run all the way down, your core. And so doing that deep breathing and that belly breathing can like calm it down.
And there's interesting stuff with vagal nerve stimulation.
Yeah.
Not just, obviously through things like deep breathing and yoga and humming, mechanical or electrical. There's things you can clip on your ear. There's other things that you can do. And they've done some studies and shown symptomatic improvement. So really, really interesting stuff.
Right. And then what about like toxic food supply?
Oh man. I think basically the standard American diet is like an IBS diet. Like you couldn't design a better diet.
Right, which, you mentioned earlier some of the statistics and how the U.S. has higher rates of IBS than worldwide, and you think, okay, well, look at what we're doing.
We're stressed out and our diet's awful. So it's like, yay.
Yeah, we're stressed out and we're eating sugar.
So food additives, preservatives, pesticide residues, these emulsifiers that disrupt the gut microbiome and disrupt the mucosal layer.
Yeah, and they're hidden in healthy food, quote unquote, right?
Yeah.
Like, so you might have something that's organic or whatever, and then it has these emulsifiers in it that's really wreaking havoc on your system.
So my kind of like list, especially for patients who have inflammatory bowel disease, but I'm like, carrageenan, polysorbate 80, carboxymethylcellulose, titanium dioxide. No. Like, get that out of there, because they're,
I think we even post that in like a handout when we send people out. Yeah, for sure. Okay.
So hormones. Back to that real quick.
Again, we'll take 2 seconds here. But so your hormones can directly impact your GI system, right? And so you can have, and this can be a natural thing too, but it can increase if you have more of like an estrogen progesterone disbalance or imbalance there. You can have more loose stools or more constipation, and it can fluctuate throughout your cycle. So if you're on a 28-day cycle versus if you're in perimenopause, menopause, right, where you're not cycling or you're having a 60-day cycle, can make a huge difference.
And I think it can go either end of the spectrum, which is where you get the IBS mixed, right?
And that's what's so hard.
Now I'm constipated. Now I have diarrhea, and that could be largely due to some hormonal fluctuations.
And we know looser stools come before you start your period. And so but is that all that's going on, or is there something else?
I think it could be compounding. So if you if you can dial back on some of these other things, and then maybe that's going to decrease the severity or the effect of that hormonal fluctuation.
And you
on
change,
some of the symptoms.
your glucose insulin, right? So you decrease your sugars, and then that can really help
the microbiome maybe can buffer that a little bit, a healthy microbiome.
So
all the things that we kind of look at.
Yeah, such a big deal.
So we talked about the 6 pillars. That was our first kind of 6 big episodes. We went through, nutrition, sleep, stress, exercise, environment, community, all these things. And just like everything, all these things affect the gut.
Totally.
And so all these things can affect irritable bowel. So I think it's worth doing a 6-pillar scan on all these patients and kind of finding out, your sleep is trash.
Yeah.
And
guess what?
Yeah, guess what?
Yeah.
Now you have irritable bowel.
Because if we don't, if our sleep, I always say, if our sleep is dysregulated, it's hard to do anything else.
Yeah.
Like it really is. It's foundational. Not that the other ones aren't, but like you can't ignore that. Even though it seems so mild, it's not.
Yep.
It's huge.
Yep.
Yeah.
So, then, and this is, again, we're not going to go into all the gory details, but then as for functional medicine providers, I think we use that and inform, good history and all these other things in the way we think about it. And then how do we rebalance the microbiome, calm down the immune system, calm down that what's called the enteric nervous system or the nervous system of the gut.
Right.
And then, we always run through what's called the 5 R's in functional medicine. So it's like the 5R framework. And this is we always think about GI disorders in this. And so that stands for remove, meaning get all the junk out, stressors, toxins, bad foods, allergens, things like that, which could also be like, do you have some bad bugs in your belly? Removing those.
Like SIBO, SIFO, all those things. Sometimes we actively get them out,
do
before.
we need to test the microbiome to see what's in there, find out the imbalances, and then replace, right? If you're not, another thing I didn't talk about is pancreatic insufficiency.
We could do a whole podcast on that one,
but that can be another cause of quote unquote irritable bowel. And I've caught a number of cases this recently where for unknown reasons the pancreas is not making enough digestive enzymes, you're not digesting the food, and then boom, IBS symptoms. So that's another thing that we can screen for, and there's a test called the fecal elastase that measures if your pancreas is up to snuff or not. But do you need extra enzymes or extra hydrochloric acid, because a lot of older adults don't have enough stomach acid instead of too much,
but yet they're seen as having too much, and so they're put on a PPI,
which causes IBS in a lot of cases.
It's like that vicious cycle.
It is.
That's what I'm gathering.
It is. And then the third R is reinoculate. So again, like
put
bad bugs out, good bugs back in.
Put the good stuff back in. Yep. Because that's the thing, is we have to remember our microbiome is bacteria. Yeah. And so we have to have enough of the good ones. So sometimes we supplement.
And enough food for them. Enough prebiotic fiber.
Food. Feed those little buggers.
And then repair, like is there damage or kind of irritation that can, using stuff like DGL licorice, marshmallow root, slippery elm, zinc is super important. Omega-3s are super important.
Yeah. Thorn makes a great one called GI Relief that's like fantastic.
And then the pure encapsulations, DGL plus, that kind of same thing.
There's so
use
many
that quite a bit.
we
A lot of
use.
stuff like that. Making sure the nutrition is such to support a healthy mucosal layer.
Like you can't keep doing what you've been doing to get you where you were and then expect that doing the same thing is going to get you out. Right? What was that? The definition of insanity is to
doing the same things, expecting a different outcome.
Yeah. So same thing there.
America.
But we're on the up and up. Here we go. So
and then the last R is rebalance. So I think that again goes back to that whole 6 pillars.
Right.
Like what are you not doing, or how do we rebalance your entire life? Because
stress, sleep, movement, community connection. Toxic overload, nature. And now we can get back out in nature because it's getting nice, getting sunny. Yeah.
So that is our quick 40-something minute rundown of how we view irritable bowel, the sort of the functional medicine approach. So if you're having ongoing gut issues, somebody or come see us here at Functional Medicine Associates of Montana.
Take a trip to Glacier if you don't live here, and come make it a medical trip.
Talk about poop and then go see the park.
And then find poop.
That's a good vacation. That's like the Rome 4 guys. You could have some wine too and almost make it like the same type of thing.
Yeah, good times.
Awesome. And as always, we thank Brandy Burke, who is our editor-in-chief.
Producer. She's wonderful. Thank you so much for helping us get through these wonderful podcasts that we really enjoy doing. But feel free to like, share, leave us a comment on any of those major platforms that play these podcasts. We'd love to hear from you. And again, give us a call. Check out our website. We'd be happy to answer questions also.
And we're always open for new ideas for podcasts. Now that we're sort of freelancing it, we got through the 6 pillars. So we're just going to kind of go through kind of common things that we see and things topic by topic.
For sure. Awesome.
All right. Have a good spring.
Take care.
Bye-bye.